Well, welcome again to another edition of our Focus on Facebook. My name is Husnain Kermalli. I am the Chief Medical Officer here at St. Mary's Hospital in Waterbury, Connecticut. Each month, we like to highlight one of our clinical departments and provide a little bit of insight on the various offerings for our patients and in the community here in the Waterbury market from St. Mary's perspective. And so today I'm really excited that I have with me Dr. Carina Biggs. Dr. Biggs is our trauma medical director for the Department of Surgery. And thank you very much for taking time out of your busy schedule to join us today.
I'm happy to be here.
So we're going to learn a little bit about the trauma program, what it is, what it does for the hospital. But first, let's talk about you. You've joined us again since 2021.
Yes.
A little bit of a homecoming because you did some of your training here. Tell us a little bit about the background that you took
Sure.
to get back to
I
St.
finished my general surgery residency here at St. Mary's Hospital in the 1990s. And then I went out to the Midwest for some time. I was at Cook County Hospital in Chicago. I came back to New York. I did my trauma critical care fellowship at Rutgers in Newark, New Jersey.
Okay.
And I spent most of my career at Kings County Hospital in Brooklyn.
Wow.
On the trauma service there.
Sure. Busy hospital?
Yes.
Lots to see down there from a trauma perspective, I
That's
imagine.
true.
So then you brought that perspective and that training to St. Mary's Hospital. How is that transition coming back?
It's been
home?
very good. Been very good. You know, the prior trauma medical director and coordinator have done a wonderful job in getting St. Mary's Hospital to become an accredited trauma center by the American College of Surgeons. So I sort of took over from that, and it's been a very good experience. We've continued to grow the program,
Yep.
to increase the volume, and to add other programs to our trauma program.
Yeah. So why did you choose trauma surgery? Of all the things and all the surgeries, you chose trauma surgery. I'm intrigued about that.
To me, it's very individual, but to me,
Yeah.
it's the most exciting thing
Okay.
in surgery.
Okay.
It's very dynamic.
Sure.
It's the one field where you have a very little bit of information, very little time to make a big decision, yet you can make a huge impact in a person's life. And certainly other fields of medicine do the same, but it's maybe not quite as quick or as dramatic. I also like the combined trauma and surgical critical care
Yes.
specialty, because many trauma patients end up spending time in an intensive care unit. So I've always been very interested in critical care. And I also love emergency general surgery, which is a part of trauma and critical care. So it's a broad field, there's a lot of variety, and it's constantly changing. So it's challenging from that standpoint. And I really love also working with residents and with students.
Yeah.
We have a very solid general surgery residency program. We have people who are interested in trauma and critical care, and I find that rewarding to teach them.
So teaching is a great specialty. And when you talk about the impact that you have on people's lives, I was at a birthday party this weekend and was talking to somebody about the impact that, another one of our esteemed colleagues in trauma surgery, Dr. David Shapiro, who's Chief Medical Officer at St. Francis Hospital, and the impact he had, where his friend, who ultimately became his friend, really got introduced to him in that life-saving moment where David, came up to the family and said, "Listen, we need to do this right away for your family member," and family member had great outcomes, but it needed that trauma immediacy to have that impact.
Yes.
So, I mean, clearly what you do touches lives day to day and every day. So, you're here at St. Mary's and we've got our trauma program. Can you tell us about what our trauma program is from an accreditation perspective, from a level
Yes.
perspective? And then let's talk a little bit about what that means to maintain.
Yes. For a trauma program to be accredited by the American College of Surgeons, there are many criteria that have to be met in order to reach that level, and on a more challenging thing to maintain that level.
Yeah.
We have to maintain a high level of education. We have to remain current in trauma. We have to meet certain numbers
Yeah.
in terms of patient volume, and we certainly we take care of more trauma patients than any other hospital in the Waterbury area. We have to meet certain criteria in terms of timing. There's no delay, so a patient comes in with an emergent condition, they have to be in the operating room. We can mobilize our operating room within 15 minutes, wow. 24 hours a day, 7 days a week, weekends and holidays included. We have a very good interventional radiology team that is essential to trauma. They can be mobilized and be doing the procedure necessary within 60 minutes of the patient arrival. We have thoracic surgery coverage. We have vascular surgery coverage. We have a broad spectrum of different surgical specialists who are available and very much integrated in our trauma program. I should also mention we have in-house orthopedic surgeons, which is rare but a luxury. We have neurosurgeons who are available for trauma very rapidly as well.
And it's amazing that we're able to provide that level of service in a community setting. It's not typical when we talk about emergency services, particularly in a sort of not a dominant city like Waterbury is.
Well, it's a huge team effort. Yeah. It's not just one person or not just the trauma team. There are many people throughout the hospital who have to support trauma, and I have to say the emergency department is very supportive of trauma. We have very good colleagues there. We have a very high-level ICU staff. The nurses in the ICU are very comfortable and very knowledgeable about managing trauma, and they care very much. And if you have a multimodality approach and you have a whole group of people who are devoted to trauma, it works well.
And then I think about where we are located.
Yes.
From a trauma perspective, and unfortunately we're right at a busy intersection from a highway perspective. We got two main highways coming together here, and so clearly the level of trauma is increased from a motor vehicle perspective. But then the other piece of the puzzle is we also have, unfortunately, some violence that happens in the community, and we are able to manage those two pieces.
Yes.
The great aspect, and we've talked about this from a couple of our different focuses, that we've got these different teams that all come together to put the patient in the middle. And it's amazing to me when I hear the trauma service being mobilized. I know that you have the tools that you need at your disposal, and that we've built this program so that patients aren't going to lack when they need that service, that the service is available in a timely manner, because that's what's needed to help them.
Yes.
So what are some of the ways that you talked about expanding the program? What are some of the ways that you've taken on to really improve the program, get it going to the point where it is right now?
One is education for our residents to make sure that they're current and continue to evolve in their field. We have very experienced general surgeons and trauma surgeons who are available 24/7 as well. Something that we've done in order to bring trauma to the community is start the Stop the Bleed course. Now this is a nationwide program which teaches all healthcare providers and, more importantly, civilians who are at the scene of a trauma to intervene, to stop bleeding. The most common cause of blood loss in any person who suffered a traumatic injury is an extremity injury, arm or leg, or something in the torso. We teach a technique, this was actually popularized at Hartford Hospital, how to place a tourniquet correctly and how to control pressure points in bleeding so that a person can arrive to the hospital and have a much higher survival because the bleeding was controlled in the field.
So what has been the impact of the Stop the Bleed program?
Just as CPR, there have been long-term studies to show that CPR has improved survival. We're still waiting on that data because Stop the Bleed is still fairly new. It's been around for maybe 10, 15 years, not longer than that, but it really has expanded tremendously over the past 5 years. And we anticipate, what we already are seeing is that patients do come in with someone in the community who say took a belt or a sock or a towel and either packed a wound and held pressure or used a belt or a tie as a tourniquet to bring someone in so that they haven't lost as much blood. They come in alive and they have a better outcome.
Yeah.
So that we've already seen. And it's a matter of continuing to teach this broadly. We teach this course every Tuesday, twice a month on Tuesdays, and this is open to the public. We've taken it to high schools. We'll continue to do that. And this is something that we're teaching our nurses, our staff, but also anyone in the community who wants to learn this. We are very, very motivated to teach it.
Well, it's amazing, and I know we're going to have this information available for our viewers as well in the description box below, to really remind them that we have this huge opportunity to empower them at the scene to do something for either the bystander or for their loved one who's gone through one of these incidents. What about new technologies or procedures? I mean, we were talking about people in terms of the services that we have available, the process, something like Stop the Bleed. What about technology or improvements in technology that help in trauma?
Probably the most important topic today in trauma management is blood transfusion. It's not really a new operation or a new type of machine, but it's actually using whole blood instead of what we've done in the past is packed red blood cells and fresh frozen plasma and platelets. That is giving blood in separate components because it's been much easier for blood banks to store blood that way. We will be using whole blood as a transfusion fluid in the next weeks with our new blood bank director, who's very current and very motivated to get this going. And that has been shown in the military data to improve survival. So that's what we'll be bringing to St. Mary's as well. In addition, expanding the intensive care unit, because we often take care of very critically ill patients. We raise the level of critical care by bringing and introducing new protocols and having real attention to those patients who need it. It's very important for trauma patients to be surrounded by their loved ones. And what we've been able to do in the past 2 years is to have fewer patients transferred out. Those patients who need to go to a certain facility that doesn't offer what we have here certainly will go. But we found that over the past year, our numbers of patients who need to be transferred either by helicopter or by ambulance has decreased significantly because we're able to take care of them here.
And that must be, I mean, when we talk about whole blood, I know people think blood is blood is blood, but clearly there are different components to blood. And we talk about, shortages in the blood bank itself, which is a whole other conversation to have. So if those who are out there want to donate blood, please, connect with your Red Cross to do so. But now having this newer way of giving whole blood, which actually has been shown to improve patients' outcomes.
Yes. And we end up having to give less blood.
Yes.
Which is also a benefit to the patient.
So we're not giving them, we're giving them the right things that they need, as opposed to giving them more things along the way in a more fragmented way.
Exactly.
A little bit more of a natural method of replenishing blood.
Yes.
So it's remarkable that it took us a while to get here, but now that we're here, I'm looking forward to that step for the future.
Yes.
But when we talk about teams and trauma, it's not simply what happens here at the hospital. I mean, the trauma starts out in the field.
Yes.
So how's our relationship, and how do you continue to cultivate that relationship with our partners in EMS, in fire, and police?
A lot of it is one-on-one. When the EMS people bring a patient here, we strongly promote a very collegial environment because they're very professional people. They're doing often the harder work. They're going to sometimes a dangerous site. They're putting themselves at risk. They're doing whatever they can to keep that person alive while they're bringing the person here, and often they're extremely helpful. So it's very important to have a very good relationship with our EMS colleagues because we want them to bring patients here. And when they get here, we want everything to be good for them as well. We give them a place where they can do their work. We give them an update about how patients are doing because they care about how the person is after they've brought the person here.
And that's the other piece. What about training with them or courses for them in terms of education?
So many of our EMS colleagues are already trained in Stop the Bleed, and they actually have a very high level of training. They're very knowledgeable, and different EMS people bring different things to the table. So it's challenging to see exactly what is going to be of value to them next, because their specialty changes and evolves very rapidly.
Yeah. And we actually were having this conversation, particularly in our emergency department and the relationship with our EMS, and really making sure that we've got aligned practices so that we continue to support our EMS, particularly upon arrival, whether it's communication beforehand or then communication during the transition. And then giving them, small little things. Like the simplest thing is, I think, making sure that they've got water available in a hot summer day, so that when they leave St. Mary's, that they're a little bit replenished after being out and taking care of those lives.
Yes.
So, when we talk about these other pieces, we're coming into summer months. We had an odd winter when we talk about orthopedic trauma injuries. It was a milder winter, so not a lot of people on ski slopes and whatnot, but summertime's around, safety again becomes an issue. What are some of the concerns you have coming into summertime, and what are some of the things that our viewers can do to protect themselves?
Summer tends to be a busy time for trauma. As you say, people are more active, people are traveling more, even if just to the beach or to see friends. So our numbers in terms of motor vehicle related injuries goes up. Also, people tend to maybe socialize more, and arguments happen more, and there tends to be more penetrating trauma, gunshot wounds and stab wounds in the summer as well. So one of the things that we have done in conjunction with Hartford Hospital is to be involved in a program called Not One More. And this is a program, an outreach to encourage people to not drive and while they're intoxicated, whether it's alcohol or now, because marijuana is becoming legal in Connecticut, we have to also encourage people not to use marijuana and drive. I'm not at all suggesting that people should enjoy the summer with whatever they like. Just don't drive.
Yeah.
Just do it at home, or have a designated driver bring you home to a safe place, because the incidence of motor vehicle related injuries goes up in the summer, largely because the toxicology that is done at every hospital when a trauma patient comes tells us whether the person is intoxicated or not. So that's how we have those numbers.
Yeah, and it really is difficult when we hear the stories, and unfortunate tragic stories, about sometimes it's not the loss of life from the person who is intoxicated, but the impact that it has on the other family that's involved, or the other individuals that are involved. And so it's not only a responsibility for one's own self, it's responsibility to maintain for other people as well.
Yes, and many of those injuries are preventable.
Yeah. Seat belts, speed limits, I imagine, go without saying, but we'll say it again.
Absolutely, seat belts save lives. The severity of an injury in someone wearing a seatbelt is much decreased if the seatbelt is worn. There are still injuries with seatbelts, yes, but much less.
Yeah.
Whether a woman is pregnant or not, it's important to be able to wear a seatbelt, and we can, there's a safe way that one can look online. Basically, strap goes across the breast and under the baby, under the pregnant uterus.
Yeah.
So seatbelts save lives whether someone is in the front seat or the back seat. Often people think that if they're in the back seat of the car, they don't need a seatbelt. Yes, you do. It improves your survival coming out of that car. So
seatbelts, we talked about. I mean, speeding, of course, is going to be a piece of the puzzle. And then what I think is very important for us to remind everybody is texting and driving, using your cell phone while driving.
That also, because there's never a text that's life-saving, but car crashes can be caused by that. Pull over to the side of the road, finish your text, have your conversation, and get back on the road, please.
Yeah. So love to see that. And I think finally we talk about safety things like helmets, elbow pads, and the such for some of our younger ones who may not be driving.
Right.
But motorcycles, I guess, wearing helmets, etc. But tell us about helmets.
So helmets decrease traumatic brain injury, period. So if your child is on a bicycle, the child should have a helmet. Okay, it decreases the risk of an injury to the brain, and it also decreases the risk of an injury to the spinal cord. So the child should wear a helmet. For adults riding motorcycles, I do understand the wind blowing in your hair must be fantastic, but we do take care of a number of people who have devastating injuries to the brain, which they would not have had they worn a helmet. Shoulder pads, knee pads are very important for skateboarders and for other sports people. It decreases the injury of major knee and elbow injuries, decreases the need for operations, and it gets you back at your sport that you love the next day.
So, it may not be the cool thing to do, to wear a helmet.
It is in the long term,
but it is in the long run,
yeah,
right? Because those small little oops, had I,
yes,
are easier to prevent. And I think this is where the ounce of prevention is better than the pound of cure, because we don't have a good cure for traumatic brain injury.
None of it. And the recovery is significant, if there is recovery.
Yeah. So, small word of wisdom. Anything else that you'd like to share for our viewers going into the summer season?
Swimming, drowning. Everybody likes to get into the water when it's warm, whether it's a pool or natural water. Children have to be obscene the entire time while they're swimming. People who swim alone are at greater risk for drowning. Have somebody with you, have somebody watching you. Try not to swim at night. I know it's tempting, but try to swim during daytime hours, because if something happens, it's much easier to intervene. Yeah,
when we talk about children, I think swimming pools as well, swimming pool injuries comes up every so often. So just simple safety in order for the summer to continue with good vibes, I guess.
Yes.
Well, I want to thank you very much, Dr. Biggs, for coming on board, and thank you all for joining, and look forward to seeing you all next time. Have a great day.